My talk this morning is ETSO Diaspora Africa. And this is where I'm coming from. My assumption is that appropriately, those of us in diaspora, particularly in healthcare, we have the prerequisite skills. We have education, we have technology, we have the skills, but the opportunities exist in Africa. And so, what I'm going to try to do probably in the next 45 minutes, is to first of all create a case, make a case for why we in the diaspora in medicine have to connect with Africa. First of all, highlighting the state of healthcare in Africa. And compare the healthcare funding between African nations, and also look at the health indicators in Africa in comparison with other continents in the world, and then discuss the potential role of African health professionals in the diaspora. And my emphasis is on professionals. I'm not talking of doctors alone. I'm talking of doctors, nurses, health technicians, hospital management experts, and then because I don't have data on every country in Africa, I'm going to kind of look at the attempt in Nigeria for healthcare reform. And this is where I might go wrong. I'm going to now speculate whether we can look at Nigeria and use the healthcare reform attempt, I keep saying, at healthcare reform, and maybe formulate a model that will work everywhere in Africa. It seems like a tall order, but I can assure you that I will go quickly. Starting first of all by asking the question, do we need technology transfer in Africa? And you go along with me. First of all, I'm asking a rhetorical question here. Is Africa a healthy continent? And when I'm asking that question, I'm asking it from the perspective of population health. It starts to say that no, they're not. Individuals, yes, might be healthy. But when we look at the continent, the population as a group, the answer is a resounding no. And the fact remains that by using all leading indicators of health, Africa lags behind the rest of the world. And more so behind poor countries of Southeast and South Asia that were even behind Africa when these metrics were measured a few decades ago. And that's pathetic. Which means when you look at Africa at some point, we were doing well. So what happened? Much of this gap has widened since the 1980s. And the paradox is that in 1980s, that is where in most places in Africa you have oil boom, particularly in Nigeria. So how come that there is increased wealth at the national level, and at the same time you have poor health statistics? Now, starting from the population, Africa is second largest and second most populous continent in the North on Earth. The estimated population is about 1.03 billion in 2013, and the projection is by 2015 will be close to 1.2 billion. So you have a scenario where most of the world population is going to be around here, about 8 to 9 billion is projected by 2050, and most of that is going to be coming from Africa. The rationale for that is a high fecundity rate, and women, looking at this data from 1980, there are about 6.7 births per woman in 1980, compared to 2.5 in Europe. In 1995, there was a slight drop to 6.1 compared to 2 in Europe. But look at the more recent data here. This is actually looking at, these are countries like Nigeria, Ghana, Syria. Look at the number of adolescent fertility rate per 1,000 women. And then this line here is comparing government expenditure. So you have a dichotomy of increased population and very minimal expenditure on healthcare. So you can tell right away where we are going with that. And then this is just a introduction here. One of the things too which we will talk about are the monuments in Africa that needs to be harnessed. That's the Doré Hills. That's the whole city right there. Going forward here, look at the infant mortality rate, another very important healthcare metrics, very high, and I identified some countries here, Burkina Faso, South Sudan, Ghana, Mauritania, Angola, Nigeria. We are looking at infant mortality rates running from 80 per 1,000 live births. When it comes to specific health indicators like life expectancy, number of physicians per 1,000 people, this is, for example, we're looking at here, in life expectancy is about 54 compared to 75 in Europe, that's Africa. And when you look at the number of doctors per 1,000 people, 2.3 in Africa. And 2.3 versus 33 in Europe. And then look at the mortality rate is under 5 per 1,000 live births, 107 compared to 13 in Europe. So, this slide I put it for a purpose. So remember, this is a class of 1985. Over 25% of this class are in Europe and North America. The estimated number of physicians, and now I have the data on Nigeria, outside Nigeria is about 6,000, not counting those physicians who are not in residency training. And so if you go back to the last slide, I talked in terms of physician, doctor to patient ratio, you can see that this is a serious problem. I'm looking at causes of death, and what I'm going to emphasize here primarily is communicable disease, about 65% of all deaths, compared to only 6.8 in Europe. And then looking at all that data, that the high population density, high disease burden, look at how much the various African governments are spending on healthcare. If you look at this, the ones here, only Malawi, somewhere in South Africa, have almost about 15% of their government expenditure on health. A place like Nigeria, for example, is less than 5%. Something very curious happened in 2001. They all met in Abuja and decided that we have to spend money on health. This is the so-called Abuja Accord, Abuja Declaration on Health. I think the assumption was that if you spend close to 14% of general government expenditure on healthcare, you will make some impact. Only 4 countries met that metrics, and that was Botswana, Rwanda, Tanzania. Now, those who could not spend up to 14%, who tried between 8 and 10%, were Democratic Republic of Congo, Ghana, and South Africa. Now look at the difference. When you look at those countries that spend anywhere from 8 to 10%, they now have what is considerably a significant impact on healthcare in terms of infant mortality, in terms of life expectancy. So what we're saying here primarily is that we have a problem. And then while you're sitting down there, I guess the question should be, what is the relevance of all this data to this meeting? I hope to establish a relevance in saying that when you look at all these statistics, and you are a healthcare professional in Europe or America, I'm speaking to myself, because there's a program in Europe which says, when you point at someone with one finger, 4 other fingers are pointing at you. So there's a considerable degree of guilt about what I'm talking about. And part of the reason why I took this conference as very important is that it is only through a forum like this that we can mobilize ourselves and get something done. So, because of this issue of doctor to patient ratio. I also want to quickly talk about training in Africa, because that is one way that we in the diaspora can participate. This is the campus of University College of the Hospital Department where I trained, and some of us here trained. Look at what is happening. Currently, if you are a graduate from any medical school in Nigeria, you have a mandatory 1-year housemanship, which they call internship in North America. Most of those graduates do not have a place to train that mandatory 1 year. So if you graduated in 2012, you are still running around looking for a place to do 1 year housemanship. Now, if you are lucky and you finish your housemanship and you want to go back and become an anesthesiologist or become a dental surgeon, this is a data from Nigeria Postgraduate Medical College. These are the available postgraduate slots in Nigeria for specialization. So most of these folks are here looking for a place to train. During the Clinton administration, they cut back on residency funding in hospitals, because if you are at hospital A and you have about 10 residents, they might give you, say, $100,000 per resident, and the salary for each resident is probably about $40,000. So the hospital was making a profit, so they closed that gap. That was when Clinton was there. But then the enrollment in medical schools increased. The enrollment increased in medical school, and so gradually, US graduates do not even have a place to train. There are, last year, about 500 US trained graduates that did not have residency slots. So, if you're coming from Nigeria, from Ghana, from Mali, it's going to be difficult for you to get into residency. How does that tie to what we're discussing? Think about 2-3 slides behind, where I did mention the doctor-patient ratio. A lot of us who are here, there are a bunch of us who are here too, who have not even gotten into training. So the question is, can we train them at home? Can we use this forum to set up a very competitive residency training program so that people do not have to leave African countries to come here and get stuck in their training? So, what I have said in the first 10 minutes is this, that there's high population density and a high disease burden in Africa. And to go along with that, there are few doctors, and fewer still, because the rest of the training is not adequate. Secondly, you have a poor sick role behavior that is aggravated by extreme poverty. The healthcare is underfunded, and even the little hospitals that are available, there's poor access, then there's inadequate and substandard training facilities. So this is where my speculation begins. If you have all this information and you're a healthcare professional in the diaspora, are there opportunities out there for you to make an impact? And my answer is yes. I want to start with, what does it mean? The basic goal of any healthcare system, very basic, as follows: health promotion and maintenance, provision of quality healthcare for the sick, affordable healthcare, and population health. So if you look at these 3 objectives, I want to submit to you that the government can take care of most of these issues in partnership with NGOs and other people who might just help for primary health care promotion, because I don't want a situation where we'll leave this conference thinking that the solution to healthcare in Africa is infusion of technology. I want to say that if we address a few of these issues, health education, promotion of proper nutrition, safe water and basic sanitation, maternal and child health care, including family planning, immunization, appropriate treatment for common diseases, provision of essential health, all this can be done primarily by the government. However, how about secondary health care? For the person who has cancer, somebody who has diabetic neuropathy, somebody who has stroke. And that's why I'm thinking that a smart government in Africa should pay attention to primary care and then create an enabling environment for infusion of healthcare technology and expertise from the diaspora. And I want to show you that Nigeria there's something going on there. I don't know what it is, but maybe if it is properly defined, we can use that as a model for other African countries. For example, most of the secondary healthcare issues can be dealt with through provision of tertiary health centers, diagnostic centers, improved access, innovative healthcare financing, because when you set up a high-class, state-of-the-art health system, you better know how to manage it. Otherwise, you have a white elephant syndrome. So, what are the opportunities out there for you and I in the diaspora? I'm thinking that partnership with stakeholders in healthcare in Africa is an opportunity. Based on some of the things that have been said this morning, if you are in health management, you can help to promote health policy initiative and training. What if the government gives loan guarantees and tax holidays to people who want to come in there and build health centers, partnership with other international foreign aid programs, etc. This is what I'm laying down as a foundational principle. So, the Nigerian example. This is what the next few slides is going to tell you what opportunities exist out there. For example, between 2010 and 2015, there was a Nigerian Strategic Health Development Plan which was supposed to cost about $26.7 billion. Now, I don't know if $1 billion has been spent or 26 billion has been spent on paper. Then there was an establishment of a national health insurance scheme. And there's a national health bill that awaits presidential assent. There's a move to renovate tertiary care centers and development of high-end diagnostic centers. And then there's increased focus on training of healthcare personnel, and then promotion of investment in the Nigerian health sector. That to me looks like a progressive strategy on paper. But this is where I want to make a point here. When you look at all the African countries, none of the African countries has a specific healthcare system, just as we have in Western European countries. And for the sake of time, I'm not going to waste the time trying to explain, but the healthcare system is determined by the following variables. Number one, who owns the hospitals? Who employs the doctors? What is the source of funding? What business model are you using? Based on those four variables, you have this big model, which is the national health insurance scheme that is used in Europe, where, for example, the government owns all the hospitals, most of the doctors are government employees, plus or minus a few private ones, and government funds healthcare exclusively by taxation. You never get a healthcare bill when you are sick in Europe. In between that, you have this other model, but you look at the national health insurance model in Canada. I think this is where you can help me out on this. In this model, hospitals are mostly private, the doctors are mostly private, and the government runs insurance program that every citizen buys into, and then there's low cost and a true collective bargaining. My submission is that African countries should be a hybrid of the two systems, because now Nigeria is trying to set up an insurance company, national health insurance scheme. If we make the mistake that we make in America and make the insurance companies dominate the healthcare system, that will be serious. We cannot afford to go that route. So I'm saying that The reason I'm saying that is that I don't believe that African government has any business running hospitals and employing doctors, given their track record. So, the current number of existing government hospitals should remain where it is and then allow innovation, technology, management skills to come from the diaspora in partnership with experts, local experts in the various African countries. Look at the out-of-pocket spending. I put this graph there just to tell you why that currently, when you are sick in any of these African countries, you pay, this is Nigeria, for example, 60% of the healthcare bill is borne by each of the households, except when you are in a place like South Africa and Malawi. So if any healthcare insurance program that any government in Africa is going to set up should cut this number to less than 20% or even zero. Yeah. That's what I'm proposing. How about the investment drive? What opportunities for investment are there in healthcare? If I ask you, look at medical tourism, for example, because when you talk about healthcare in Africa, the instinct is to say, oh, you guys don't do anything, just take care of malaria, clean your streets. Yes, I agree that we need good primary health care, but people are sick. People have very serious illnesses that require expertise in tertiary healthcare centers. Look at, for example, sorry about that. Medical tourism costs about 250 billion naira annually in Nigeria. And where do they go? The top destination is India, USA, Europe, and the Persian Gulf. And in 2012, over $260 million were spent. Can you imagine that if those of us sitting down here collectively will decide to provide state-of-the-art care, tertiary care, and keep that 260 billion within the country, and you can replicate that model anywhere in Africa, it will not only will the healthcare be satisfactory, but you have jobs created because you are producing something within your country. As an ICU physician, the one thing that you never want to happen to you, anybody in here, is to have a serious life-threatening illness, and the way nobody speaks your language. Think about that. And go to facilities where there are no regulations or control, because there's no oversight. However, what is driving the healthcare market in Nigeria is a growing middle class who are now demanding for quality service. And of course, we now have a national health insurance scheme. This is from National Geographic, telling you that the Nigerian middle class in 2014 there were about 4.1 million. The number of individuals that can be classified as middle class, and they constitute 11% of the current population, and the projection by 2030 this number will go to 7.6 million. Look at how much they're spending. They're putting in the economy in dollar terms. In 2010, it's about 24.4 billion. It's about 320.2 billion in about 2013. And in terms of the largest economy out there, GDP, Nigeria, South Africa, Egypt. So what I'm saying, if you're a venture capitalist and you want to put your money in healthcare in collaboration with stakeholders in Nigeria, you're not going to lose your money. There's a market for the service that you want to produce. That's the essence of this slide. Because we're now talking about opportunities. How about capital infusion into the economy by Nigerians in the diaspora? Right now, because you send money to a sister or an aunt who needs CT scan, who needs MRI, who is sick, who needs to go to school, by World Bank estimate, you are infusing about 20 billion. This was in 2013 into the Nigerian economy. And this is projected to increase to 41 billion in 2016. And Nigeria is the first in Africa and the fifth largest recipient of foreign remittances. Ladies and gentlemen, this is how we subsidize inept and corrupt government in Africa. When you pump this kind of money in any economy, nobody's going to make them accountable when they don't provide necessary infrastructure and healthcare. What I'm saying is, maybe through a forum like this and partnership with our African American brothers and others, maybe some of these monies can be channeled into healthcare. And I'm saying that there's an emerging middle class that can patronize these services. So you're not going to lose money, because I'm not going to deceive you. If you're going to put money into something, you're looking at return on investment. If I was sick in Nigeria, instead of traveling to India, I can tell you Nigeria would value health, and I'm sure it's the same thing in Ghana. And the only country now that doesn't require this is probably South Africa. And I'm looking at Botswana and Rwanda. So even I'm not trying to say that this is a Nigerian issue, but I only have specific data on what is happening in Nigeria to make my speculation. Forget about building hospitals, etc. How about medical devices? Are there opportunities? So if you're a healthcare professional and you're not a doctor, you're not a nurse, look, the medical devices market in 2013 is about 154 million. It is forecasted to reach 227 million in 2018. What are they doing? Diagnostic imaging devices. But like and I, we were talking yesterday about CT scanning online. And along with what Henry said, we don't want any white elephant project, but there are specific strategic areas in most African countries where people in the diaspora can contribute by, making available state-of-the-art technology in communities. Are there reasons why potential entrepreneurs will have calculations or palpitations about investing in Africa? Yes, there are. Corruption, infrastructure, etc., etc. However, even if you take care of that, high costs of diagnostic and surgical services, that brings up the issue of, can the populace afford it? That is where the national health insurance policy comes in. If they have a specific health system that guarantees access, regardless of your economic status, that will take care of this problem. But then the one I want to emphasize here is shortage of trained healthcare professionals, because you cannot move all this expertise across the ocean if you don't have individuals that can run it. Maybe the hospital, maybe the MRI machine, or the CT scan. I found, just as I was preparing for this, I found something in one of the Nigerian newspapers. They call it the Nigerian Health Leadership Academy. I think it's very interesting what these folks are doing. This is the Private Sector Health Alliance of Nigeria. And there's another organization called the Health Strategy and Delivery Foundation. Look at what they're doing here. They are partnership with Institute of Health Improvement in Cambridge, Massachusetts, and Duke University. What are they doing? They're trying to train local manpower in Nigeria on health management. And I think this is a very, very visionary move. Because one of the things that happens is that you set up all these hospitals, nice buildings, and you go there back there in 6 months because nobody can run it well, it's in shambles. So there's an opportunity here for training manpower. What are the areas of focus of this organization? They are closing capacity gaps in the health sector by focusing on financial management, leadership and organizational development, quality improvement, and population health. Let me close by thanking Brother Elijah and all the members of the board of directors of this organization. When I was leaving medical school in 1985, this guy here, Professor Montefiore, was the assistant provost of medical school. And he gave the valedictorian address, which he titled Ex Sege Monumentum. At that time, I did not know what executive management was, and I can care less. However, with time, this lecture has caught up with me. Executive momentum is simply that to create a movement more durable than gold. When we have spent our time and it's time for us to depart, how do you want to be remembered? I think it's very important for us to create a lasting monument through service to our motherland. There is a Jewish nation which I think we should take from this. When you started this organization, what I read, there were 3 of you, right? I think you should take solace in this statement that it is not your obligation to complete the work, but neither are you free from taking the first initiative. You have taken the first initiative, and to the rest of us in this gathering, all of us, and I mean all of us in the diaspora, we are put into circumstances that call out for action, whether they involve poverty, human suffering, etc. These circumstances give us a great chance to justify our gifts, our skills, as doctors, nurses, engineers, whatever we do. That is where I would like to stop. That is my better half. I'd like to point your attention to this book by Howard French. It's titled Africa, China's Second Continent. If you haven't read this book, and you're African, or you have the African blood in you, go and read it. There's a wave of second colonialism now in Africa. Why? Because you and I are sitting in our comfort zone in Europe and America, where these folks are exploring, they call it exploration, I guess. They're exploring the African continent, but they're not going to do anything that you and I will do. I don't even need that. They're not going to do it. Why? When they go in there, they're going there primarily for the profit motive. But when you go, even though you want to return on investment, you also have another very important value that is driving your initiative. You want to be relevant. You want to make a difference in the life of your people. If you read that book, you'll see how Chinese are invading the African continent, and the quality of the service they render is substandard. Secondly, they treat the folks there in a very racist way. I don't have anything against anybody, but if you are from Europe or America, when you go out to invest, you better follow the rules, because the State Department and the US government will go after you, but the Chinese government will care less. Most of those counterfeiting and stuff you're talking about, some of those products are made in China. So ladies and gentlemen, I think we ought to thank Brother Elijah for being a missionary. And I think that, someday we will look back and say that we met today in Oklahoma and set the tone for progress in Africa. Thank you.